So we are looking at our first day of fitness assessments here. We're going to talk about some common static postural distortions. So there's a lot of like assessments that we do as trainers, right? Like we've got a cardiorespiratory assessments, we've got several different posture assessments, and they all kind of look for different things. But the sort of baseline sort of flat version that we're going to look at is our static postural assessment. So this is going to be almost like our foundation for the rest of our conversations on posture, where we're basically looking for these three very, very common postural distortions, which are commonly referred to by the person who sort of like, really started studying them in depth. They're called Jonda's postural distortions. And so Jonda was this, big studier of posture, and basically they were looking to see like, what are the three sort of most common distortions that you're going to see in people. I'm kind of surprised I'm not getting like a singular picture with all three of them here. That's not good. And what those three major postural distortions are going to be is you're going to see pronation distortion syndrome, which is going to look something kind of like this. It's where you'll notice someone who kind of stands sort of like knock-kneed, where their knees are kind of caving in, their feet are kind of flattening in like that. Sometimes you'll see ankle pronation. Often you'll see ankle pronation. And so we're seeing this kind of like alteration there, right? Where people are sort of standing in a way that is sort of counterintuitive, right? You can even see here, this person's actually like caving in, just statically standing, right? And so there's a little bit of like alteration in there that can put pressure in the low back. Obviously, it puts pressure on the knees. So that's a really, really big one there. We're also going to see, what we talk about all the time, because it makes a good example for posture stuff. But we see lower cross syndrome, where we see that sort of excessive anterior pelvic tilting, which often will move up the body into the upper back as well. We'll talk about the upper back here in just a second, but generally when we're looking at that lower cross syndrome, we're seeing, way too much excessive like anterior tilting of the pelvis, right? So those weak abdominal muscles are kind of falling forward and getting stretched out, and the low back is tightening up, the glutes are really, really weak, and the hip flexors are kind of tightening up. And then that's often associated with upper cross syndrome, which is what we see here in the upper body. We see that forward head posture, rounded shoulders, elevated shoulders, things like that. So those are sort of the three big ones we're going to spend our time talking about today. We're going to talk about why, and then what we can do to sort of like, fix those types of problems, right? But we're also going to sort of work our way through looking at, really what a fitness assessment is for. So we're kind of laying the foundation for what we're going to kind of pick up on afterwards. Like today we are just really looking at like these postural distortions and stuff. But for the rest of this course, we're going to be going over cardiorespiratory assessments, physiologic assessments, circumference measurements, things like that. So the purpose today, we are going to look at the techniques to build, it says a complete fitness assessment, but really today we're just looking at static assessments, provide us with information about how the body is supposed to move versus like how these muscle imbalances sort of affect the kinetic chain. And then we're going to be able to explain like the components and rationale. And this says for an integrated fitness assessment, again, today we are really just looking at static posture assessments. We're not looking at overhead squats. We're not looking at pushing and pulling assessments. Integrated would also mean we'd be doing like a little bit of cardiovascular work. We're really kind of keeping it simple here. So just sort of introducing everything with some of our statistics, because NASM freaking loves to start their chapters on like, everybody's in really bad shape. Here's why you got to do fitness assessments. They love to start with all like the kind of panicky statistics here. So in 2008, physical activity guidelines show how incredibly inactive Americans are. That's back in 2008, by the way. Like that was a long time ago. And things have gotten not better. And so what we found back then was that people were getting as little as very, 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 very little activity, very little exercise. And so they were looking at like, okay, if people are getting such a little amount of physical activity, what is the bare minimum that would sort of have positive benefits and reduce your risk for disease? And what they found was it can be as little as like 2.5 hours a week can be enough to really prevent a lot of these chronic illnesses that we often kind of struggle with. And 2.5 hours, that's basically equal, to about 150 minutes of activity per week. So if you're going for a 30-minute walk 5 days a week, the benefits that it has in terms of like reducing your risk for disease are astronomical. That's the bare minimum that they really recommend. Is it the best way to like improve your health? Maybe not necessarily, but it's definitely enough to kind of keep you from catching anything. Um, and what they found was only about 31% of Americans are actually getting that amount of physical activity, which makes a lot of sense considering that we are seeing, obesity on the rise, diabetes, heart disease, and all of the different types of cancers are all growing at pretty alarming rates. And so, there is our need. There's why we need personal trainers in the world. This is why I love what I do, right? I'm excited to be a part of, in what my opinion is a very important industry that can help a lot of people. So the more trainers we've got, well then the more people we've got who are exercising. And so but however, there are, and I'm sure you guys have seen this if you go to the gym ever, a lot of not so great trainers out there. And so in order to be able to properly train people, in a way that's actually going to have those positive benefits, an accurate fitness assessment of readiness is very, very important. We do need to kind of get a pretty good baseline of how our client actually like moves in order to understand like what we should do them, like for instance, like I love this exercise. Like I think that the prone cobra is a great exercise. It is really terrific for strengthening your low back. It's really terrific for strengthening your middle and lower trapezius. This is a terrific exercise. I'm not sure I like the head posture here. I would definitely prefer something like this where your eyes are on the floor. But eventually he could modify and get up to his, feet up as well. Love this exercise. It's great. However, that's not for everyone. For instance, like if I had a client who does have lower cross syndrome, right? They do have that anterior pelvic tilt. These muscles in the low back that you're using during this exercise are already a little overdeveloped. So this is not really the most appropriate type of exercise for that person. Instead, I need to strengthen the front of their core and their core stabilizers. Rather than focusing on like a cobra or a Superman or back extensions. Another exercise that I love, I think this exercise is great. But rather than doing this, if somebody has an anterior pelvic tilt, they don't need this. Their body is already naturally sort of doing this a little bit more often than it really should be, right? So instead, I need to focus on like core stabilization exercises, something more like maybe like a hollow rock hold, this would be a really great exercise that, it doesn't look like much, but this is like a sort of a harder version of a plank. This is actually, by the way, probably my second favorite ab exercise. I freaking love hollow rock holds. These are incredible for you. And then eventually you can kind of get into a full hollow rock, which I know looks a little bit silly. Okay, well, that's not quite enough motion to give. It looks a little silly, it's kind of just like a rocking banana peel, or I guess just rocking banana, not a banana peel. But this is a shockingly difficult exercise. Like ask any gymnast and they'll tell you that they spend hours doing hollow rocks. So that is, I need to know the difference between like which exercise does what kind of thing and what should be applied most effectively to my client based on their specific posture. I don't necessarily always hate like cookie cutter, workouts. We call those canned workouts, by the way. Like a canned workout is basically kind of like when you go to the store and you buy like a can of green beans, they're good to eat as it is, like you're kind of already set. but it's not necessarily for everyone, you know? I think canned workouts can be a really effective tool in your tool belt. If you come up with, if you write a routine and you're like, man, this really hit kind of everything in the body. This is really good. It burned a lot of calories. If you come up with a workout like that, and you want to write it down and hand it out to several of your clients, I think that's great. It's a really good supplemental tool, but it shouldn't be the foundation for like all of your training. I can't stand it when I walk into a gym and I see like a trainer who's kind of like carved out like the corner of a gym, where they're like, you know, they grabbed like, you know, a couple pairs of dumbbells and they grabbed like a step and a mat, you know, and they kind of just like set themselves up in one corner all day. And it's like, hey, Jim here, you know, and then you put him through the workout. And then you see him like an hour later going through, you know, Sally, and she's doing the exact same workout. And then an hour later, he's going through Bob, and Bob's going through the exact same workout. And it's like, you know, all day, they just kind of set up one little thing and take all their clients through it. That's not a very customized approach. You're not really like putting any emphasis on, you know, filling in that person's gaps and sort of taking advantages of their strengths, right? You're just sort of giving them a general workout. And again, general workouts actually do have their place. I think they're a great way to kind of burn a general amount of energy, get your metabolism activated and things like that. I would rather someone do general workouts than nothing, for sure, you know, but it'll never be as good as a customized routine that's actually addressing the problems that your clients have, you know. And we've all got like sort of our different things, you know. I think everybody in here probably has things that they're exceptionally good at and things that they're, you know, not so good at. Me, for instance, I like love pull-ups, but I am not great at pull-ups. Got these big long noodle arms, you know, that have to travel what feels like a freaking mile, you know, to get my chin up over the bar. And also I'm not willing, I'm not willing to accept any pull-up that does not at least touch the bar to the very top of my sternum. So I'm pretty picky about how I do them as well. And that's something that, like, you know, if someone was doing a fitness assessment on me, oh, that is a huge, get off of me. Sorry, there was a huge spider on my leg. So if, where was I? That's so distracting. You know, if someone was assessing me and they were like, oh, he really struggles with like his latissimus dorsi strength, right? That is something that we can approach through like maybe throwing an extra set in there per week, or maybe an extra exercise, or when you're focusing on upper back movements, rather than like rowing actions like this, which are going to more activate the lats, because your lats aren't in charge of horizontal abduction. They're in charge of shoulder extension. So rowing actions like this would be better than this. Whereas somebody else who might have like a really bad rounded shoulder situation, right? We're trying to get them to like roll their shoulders back. We need to focus on getting them to pull back this way. So instead, this version of a row would be a little bit better, right? So that's kind of what we're talking about with fitness assessments, right? We do want to we're using all the information that we gather from a fitness assessment to be able to write a very specific customized program for our clients, right? So a fitness assessment, by definition, is a systematic problem-solving method that provides the fitness professional with a basis for making educated decisions about exercise and acute variable selection. Basically, if we break this down, right, it is a system that is going to put specific different types of stress on our client, right? That's what it really, if you think about what an assessment is, right? You look at someone, if you don't see anything, you put a little bit of extra stress on them. If they still don't give in and everything moves perfectly, great. And then we put maybe a little bit more stress on them, right? Until eventually we're starting to see maybe their posture break down, and we start to go, okay, well, this is the thing that's like happening. And I'm not saying like we're digging, you know, like I think sometimes like there's sort of another misconception here where it's like, you know, because we're kind of like, we're like, does this do anything? Nope. What about this? And then we kind of give it a little bit harder and harder. We're not necessarily just digging around trying to find something wrong with our clients so we can be judgmental, you know. We just really want to figure out, like, you know, if your client has any gaps, we want to put enough stress to kind of reveal those gaps, so that we can sort of address them through our exercise programming and templating and things like that. So it's a problem solving method, right? And it allows us to allow educated decisions about exercises, but also acute variable selection. So it's going to help us choose which version of an exercise to choose, right? Should I have done a hollow rock or should I have done a Superman? Well, it depends on your client. For me, I've got kind of an odd, I've got sort of a less common postural distortion. I have a real problem with my lower back strength. My lower back is certainly much weaker than my abdominals are. And my stabilizing abdominals are a little bit weaker than my moving abdominals. Like the muscles in my abs that like to do crunches are terrific. But the muscles in my abs that like to kind of stabilize sometimes or maybe work in the opposite direction, not so great. That's like something that I tend to struggle with. My theory is that it's from years of teaching group exercise classes with like lots of crunches and stuff. But it's almost like I've trained my spine to be better at moving than I've trained my spine to be better at stabilizing. And that can cause postural problems, like now when I squat, my pelvis really likes to kind of try to rotate because my abs are like, trying to stabilize my spine. But rather than stabilizing, what they try to do is move my spine instead, because that's what they're kind of good at. So I need to do less crunching exercises and more like stabilizing exercises, right? Things like hollow rocks, things like Supermans, things like an ab wheel, and even an ab wheel is a little bit too much movement. So that's, again, there's our exercise selection, but the other part of it is also acute variable selection. If you've got a client who is, let's say you assess them and you find that they struggle with their cardiorespiratory system. They're not so good at the cardio, if you find that that's the case, well, then that's something we want to develop. It's something we want to build up. We're going to build a foundation for our client. We're probably going to focus when it comes to strength training, considering that like the cardiovascular system is the most important thing for us to kind of keep alive, because it is literally powering your entire body. Well, then we're probably going to put a little bit of special emphasis on doing probably high repetitions. Those higher repetitions are going to mean that like you are getting more into an aerobic state rather than an anaerobic state. And then we're probably going to give them a little bit of limited amount of rest. And some of you guys might be thinking, it's like, well, doesn't higher repetitions, low rest mean building less muscle? And yeah, it actually does. But that's where, again, looking at the individual that we're training, if my priority is to develop their cardiorespiratory system rather than to develop their muscular system, yeah, I'm going to sacrifice some of that muscle building to make sure that their heart and lungs are strong, So that's what we're looking at sort of in a fitness assessment right now. Big thing to remember here, and trust me, I can almost guarantee you'll actually get this question on your real test. I have a theory. I know that like they say that all the questions are like randomized and stuff, but I swear there's like a few staples that are just in everyone's test. And this is one of them. The fitness assessment is not designed to diagnose anything ever. Okay, if you ever see the word diagnose, immediately start thinking, no, that's what we're not supposed to do. Okay, we are not medical professionals. We are personal trainers. We are fitness professionals. It is not our job to, look at someone's blood, perform a blood pressure assessment and say, oh, wow, that's hypertension, and then all of a sudden start being like, well, you need to do this and that and do all these things that are going to treat hypertension, right? Not our job. Like our job, if we discover that our client does have high blood pressure, is to say, hey, this is outside of normal ranges. You really should speak to your physician. Our job is not to diagnose any condition. Our job is to observe our client's structural and functional status, and then that is going to help us determine a starting point from which we are going to sort of work from, right? Fitness assessments are not intended to replace medical exams. Too many freaking personal trainers are into this whole, idea of like a really advanced fitness assessment, and then they start speaking to their client about like how they're gonna treat this and cure that, and it's like, man, those are just words that you should not be using. Don't get me wrong, if you tell me you've got like, if I discover you've got a knees caving in posture, oh absolutely, right, I'm gonna say, yeah, we're gonna fix those knees caving, we're gonna get you better at not doing that. And let's say your client complains to you and they say, hey, I got this really bad achy, burny, uh, rubbing sensation on the outside of my knee. If they describe like this outside of their knee is like rubbing like crazy, right? And it feels like tendonitis. If my client describes something like that, right? Again, if I am not going to, they're like, I don't know what this is. I just feel like I have this really bad kind of rubbing sensation on the side of my knee, right? This is also more commonly known as iliotibial band syndrome. And it is where this IT band, this big lump of fascia here, starts rubbing on the side of the knee. It starts rubbing on this little condyle right here, which creates a little bit of pain. Our job is not to diagnose this. Our job is not to say, oh, maybe it's runner's knee. That is not what we do. However, we can absolutely say something like, well, if you think it's something serious, you should talk to your doctor. However, one thing that we do know about your posture is that you've got, and generally people who get IT band syndrome are people who have knees caving in problems. A lot of times you will see people who move like this. This is what causes that rubbing sensation on the outside of the knee. So we're going to look for that. And if we observe it, right, there it is, actually. You can even see that's a great picture. You can see like the caving in, right? Right, rather than being kind of like the bones being aligned here, the bones are kind of collapsing inward, right? That's what's causing this rubbing sensation right here, because now this muscle, this IT band, gets stretched out over this condyle, and now it's already in a lengthened position, and it's going to get stretched out even further to insert down here where it's supposed to insert. So now it rubs on the side there, and you'll see it in people who are scoopers, or people who are like dropping their pelvis like this, right? This is definitely not what we want to see. So that's the thing. That's something that we can observe and absolutely address. Like if your client has like an ankle sprain and they're like, they come back from that ankle sprain and they say, I've been experiencing like a little low back pain after my ankle sprain. And it's like, that makes a lot of sense because you've been using one side of your glutes, but you've been kind of gingerly stepping on the other side. And now your glute is sort of underdeveloped and you've got this imbalance between the two. We can address that through general exercise, but we are not diagnosing medical conditions. We are not treating medical diseases. We are not curing things, right? So here's a big list of do nots, okay? Do not diagnose medical conditions, right? Obtain exercise or health guidelines from a physician, a physical therapist, or a registered dietitian. So each of these people in these fields, right? So we are certified professionals, right? Like you're going to be a CPT, a certified personal trainer. Each of these types of people, like physicians, obviously, are medically trained professionals who have medical licensures. Well, so are physical therapists, and so are registered dietitians. Registered dietitians are not the same as nutritionists. I know I've talked about this before, but it always bears repeating. You are going to be a nutritionist when you get out of here. We're going to have our fitness nutrition specialist. But there is no certifying agency. There's no sort of watchdog agency that looks over all of like the various nutritionists that are out there. And like ensures that they have like a common practice or anything like that. So because that doesn't exist, this is going to be kind of a weird sentence, but in the eyes of the government, technically there is no such thing as a nutritionist in the eyes of the law, right? But there is such thing as a registered dietitian. They have a very strict rules, set of rules and like standards and practices that they have to follow. So that is going to be sort of a big thing for us, right? You can absolutely talk about nutrition with your clients. You can help them calculate their macros. You can help help them come up with strategies to increase like the greens in their diet. But what you cannot do is tell your client how many cups of broccoli to eat per day. How many ounces of salmon they should be eating. Broccoli and salmon are incredible for you, but that is not the type of thing we need. We can say something like, hey, salmon is a really good source of like healthy fats and a really good protein. You might consider increasing that in your diet, and that, has been shown to be really good for people's hearts, right? You can educate your client and guide them there, but do not tell your client, I want you eating 4 ounces of salmon every day. That is prescribing food, and that is super outside of our depth. So we don't diagnose medical conditions. We do not prescribe treatment. If your client needs treatment of any kind, send them to a qualified medical practitioner. We don't prescribe diets or recommend specific supplement use unless we are specifically qualified. That's kind of an interesting definition at the end there, that unless qualified thing. So we are not allowed to prescribe diets unless we are a dietitian. Like I said, nutritionists, right? Not a thing. Also, when it comes to telling your clients about supplements, you can educate your clients on supplements, but again, you cannot tell them to take them. However, supplements, oddly enough, are not regulated by the FDA. And so if you are like, weirdly certified at a gym, like let's say you work at like 24-hour fitness, right? 24-hour fitness has like a line of supplements associated with it. That's, it's like the same kind of stuff you'll find in GNC for the most part. But if you are like, they have like a supplementation course that you can kind of go through, and they encourage every trainer there to try to get their client or to try to purchase a little bit of those, like, supplements from the juice bar or wherever they're at. If you are specifically certified in something like that, what you can do is you can say like, well, you would fit into, based on all of your statistics, the green category, or you would fit into the yellow category, right? If you broke something down like that, and then you were to show them like, here's a line of supplements that sort of like adhere to that sort of category, you might look into these. You can guide them to stuff like that. That's a very different way to have the conversation than, I want you to take 5 milligrams of melatonin every night and it'll help with your sleeping. You know what I mean? So again, it kind of comes from an education standpoint rather than a prescription standpoint. And that is really like a distinct line for us. We don't provide treatment for any injury or any disease. Obviously, aside from basic first aid, you are absolutely, by the way, guys, someone brought this up, I think last mod, or maybe the mod before it. If your client sprains their ankle in the gym, of course you are allowed to help them. Yeah, absolutely. You can, give them an ice pack, basic first aid, things like you can stop the bleeding, right? Like things like that. Like you are totally allowed to do those things, just like you're allowed to administer, CPR and AED if the, emergency ever arises. But we don't provide treatment for any specific like diseases. We are not, treating a disease. Now, that being said, like, let's say your client has like diabetes, right? Again, through your guidance and education, you can totally show them tips and tricks for how to reduce their sugar intake, which is obviously going to have a positive impact. You're going to put them on a general exercise routine that's going to like enhance their glucose sensitivity. And who knows, maybe after working with you for a little bit of a while, they need less of an insulin, right? Boost. And so they're like, if they start saying like, man, I've been feeling like, really tired lately, and I've been getting like nauseous again. And it's like, you might encourage your clients like, well, we've been working with each other for a little while. You had never exercised before this. It might be time for you to talk to your doctor about, your insulin prescription, right? we would never say something like, oh, you're taking too much insulin now because you're much more sensitive than you were when we first started. We've increased your insulin sensitivity over the last few weeks. You should take we would never say something like that. But you would absolutely say something like, well, maybe go talk to your doctor about adjusting your insulin intake. And I've worked with plenty of clients who have gotten off insulin entirely, as they started like training and stuff. And so like that is, that's the kind of approach we want to take. We don't provide rehabilitation services either. So our job is to design exercise programs after our client is released from rehabilitation. Again, we're not physical therapists. We are going to be corrective exercise specialists, but there is a distinction there. Corrective exercise specialist, our job is to either prehabilitate someone to keep them from getting injured by observing their posture and fixing it. Or our job is to sort of get someone back to where they were strength-wise after an injury. So a lot of people think that that's like what a physical therapist's role is. A physical therapist's role is to get you back to functioning status. Our job is to get them back to their athletic status. So there is a little bit of a difference there, and so we want to make sure that after your client has been rehabilitated and whatever structural problem they were dealing with is back to at least neutral, our job is to get them back to, full strength, or, get them back to being more resistant to damage so it doesn't happen again, chances are if your client did sprain their ankle, if they did have some type of knee problem, joint problem, shoulder problem, whatever, if they did have some type of problem like that, it is likely due to the way that they live their life. It is likely due to their static posture, their dynamic posture, how they move. And so now it's time for us to kind of address those things and hopefully keep that kind of thing from happening again. And then the last thing, we do not provide counseling services for our clients. We are coaches to our clients, and we can focus on helping our client in their current status, and we can help them in structuring goals that they want to move forward to in the future, but we do not dive into someone's past and apply counseling. That is absolutely outside of our scope of practice. So do not try to apply, counseling techniques. We are coaches. There's definitely a distinct difference there. So that is sort of the big do's and don'ts, although it's mostly don'ts. Now let's go ahead and break down how we are actually going to use the rest of this fitness assessment, right? So the program of fitness professional designs is only ever going to be good as good as your fitness assessment. So it's really important to make sure that you are applying an effective assessment. You got to go digging around in your client's posture to kind of figure out what's going on to ensure for not only a safe program, right? Like if your client has, let's say severe arthritis, maybe lunges are not exactly the best exercise in the world for that person, right? So we got to look at that. And then we also want to look at the effectiveness, right? If we know that our client doesn't have a good capacity to grow in a specific area, that's something that we need to adjust. So we're going to use a variety of observations. We've got a lot of different types of observations that we're going to apply. There is our subjective information and our objective information. So I've put a little this is actually kind of these are actually my notes here, but I kind of want to break down conceptually again what a fitness assessment is. And basically when you think about what a personal trainer does, our entire industry in 3 steps, right? Our first job is to identify the problem through an integrated fitness assessment. So the 3 steps to working with any client always starts with identifying any problems that there happens to be. So our job is to identify any goals or any issues that our clients might have related to their structural capacity or their functional capacity. So I'm looking at someone's posture, I'm looking at someone's cardiorespiratory capabilities, I'm looking at their goals, I'm looking at their physiology, like, body composition and things like that. I'm looking at their performance. And after I've gathered all of that information, now I can sort of address any problems through my program that I'm going to write for them. So we are going to solve that problem through integrated program design. So we're going to interpret the data that we collected from our client, from that fitness assessment. We're going to interpret that data and write a program that's going to actually address any of the dysfunctions that our client happens to have, right? So if our client has rounded shoulders, right, and I identified that through my fitness assessment, then I'm going to write a program that addresses that through, doing like a wide grip row, and then I'm going to implement that solution with integrated training. So step 3 is the simple one. Step 3 is, train them. Take the program that you wrote and actually go do it, implement that solution by training your client for their prescribed solution, right? So we identify the problem, we solve the problem, we integrate the solution, right? Or implement the solution. Perform a fitness assessment, write a program based on it, train them. So again, it's not designed to diagnose any condition. It's to observe your client's structural status. It gives us a starting point. It does not replace any medical examinations, but it is going to allow us to write effective programs. So I'm going to skip forward a little bit. This is going to go through some subjective information that we are going to come to in a couple days here. And I'm going to jump all the way over to our objective information on posture assessments. Come on. Okay. So looking at posture assessments, right? When we talk about like what posture is, a lot of people think it's like, oh, it's how rounded your shoulders are, right? That is a version of posture, definitely is an example, but it is not all of what posture is. Your posture is where any movement that you make is sort of originating from. So every movement needs like a base of support from which it is either generating force or, accepting force, like either concentrically or eccentrically moving, right? That is basically what your posture is. And so it is a good way to think about it is the alignment and the function of all of the components of your kinetic chain at any given moment. So we want the kinetic chain to be rest in neutral positions. One of the things that I always like to show people is what is called your Q angle. You guys might remember this from kinesiology, those of you who have been through that class. So when you look at, that's not quite as good as I want. I want a better bony picture. There we go. That's exactly what we're looking for. So there's a concept related to like your hip and knee and ankle posture called your Q angle. And what that is if you were to draw a line from your ASIS, which is that little knob that you feel in the front of your pelvis, if you drew a line straight down from there to the center of your kneecap, and then if obviously we had just like another line that is perfectly like 90 degrees up and down, the angle between that like is a pretty sharp angle, right? That is normal alignment. That's what we're looking for. But if you look here, take a look at this version, right, where this person's actually like caving their knees outward. Like this person's got that sort of John Wayne bow-legged posture, right? Well, here it's like that angle, is decreased, right? Look at how like narrow the angle is here, right? There's barely any space between there. So that's that's an increased Q angle. And then over here, we see sort of the exact opposite. We see the knee caving in, right? We're seeing, did I say increased? I meant, sorry, decreased Q angle. We're seeing a decreased Q angle here. Over here, we're seeing an increased Q angle, right? And now look at what's happening in the knee. Right here, look at how there's even space between the different condyles of the knee, right? That's an evenly distributed knee. But here, because the knees are caving out, this part of the bone is grinding, and this part of the bone has like a huge gap. So there's instability on this side, and there's a grinding action on this side. And then the exact opposite is true with the knees caving in, right? We see a grinding on the outside this time and a big gap on the inside. So their hip, knee, and ankle posture is affecting their Q angle in really negative ways. And that means that their human movement system, their kinetic chain, is out of alignment. It's not going to be able to produce force very effectively. It's not going to be able to reduce force very effectively. Certainly not going to be able to stabilize very effectively. And so there's going to be instability and problems inside of that joint. That's going to lead to, functional problems and probably some type of overuse injury. So we need to be able to create proper movement patterns. And that's why posture is such a big part of our conversation, where we spend so much time on it. I mean, we literally have, if you think of PFT 101, it is the posture class. We're definitely going to have some cardio stuff in here as well. But we spend a lot of our time talking about posture and performance. So it ensures that the muscles are optimally aligned at proper length tension relationship. So we're coming back to that length tension relationship conversation, right? An overactive versus an underactive muscle. We want this nice neutral angle right here, right? We want to have muscles that are equally pulling on both sides of the joint, or at least they are able to pull on both sides of a joint, rather than one muscle that's pulling too much and another muscle that's not pulling enough. That is going to lead to structural inefficiency, right? And probably some type of overuse injury. So while we're looking at this, without proper postural alignment, we set our body up for, a series of traumas is what they're saying here. We call them predictable patterns of muscle imbalance. Basically, we are going to look for, in static assessments, 3 things, in the overhead squat, 5 things, in the push-pull, 3 things. Like we're looking for these specific things that are pretty common amongst all of our clients, right? It's like, we know sort of what problems are generally associated with postural distortions. So we call them our predictable patterns of muscle imbalance. And you want to have all of them memorized, right? You want to have a pretty good idea of like what most people might be dealing with, right? So a muscle imbalance, like I said, you can kind of see here, right, is where there is one muscle on one side of a joint that's pulling way harder than it's supposed to be, and another muscle on the other side of the joint that's not pulling enough, right? You've got an overactive shortened muscle over here and an underactive lengthened muscle over here. By the way, I'm not sure which term they will ask you on your tests. NASM really likes to kind of change it up. Sometimes they'll say overactive, sometimes they'll say shortened, sometimes they'll say contracted muscle. Versus sometimes they'll say underactive, lengthened, or relaxed muscle. Either way, it's causing a postural distortion, right? This happens due to poor posture and just poor body awareness. It happens due to repetitive movements, lack of daily movement. All of those things are going to lead to these kind of common postural distortions. And those postural distortions, like I said, are going to lead to injuries. So today we are going to talk about 3 big ones. We're going to talk about they're kind of like the 3 originals, like before we decided to start putting more stress on people, these were the types of things that we were observing that already told us about someone having maybe a little bit of dysfunction. So these are the jaundice postural distortions, right? And there are 3 of them. You are going to see pronation distortion syndrome, lower crossed syndrome, and upper cross syndrome. So what the heck is pronation distortion syndrome? Well, this is going to be characterized when you are observing it in your client. It is a static posture that is characterized by a flattened or externally rotated feet. So you're seeing here, right, the ankle is slightly turning away, but they are definitely rolling the inside of their foot downwards. They are doing, what that is called pronation. And pronation is a combination in the ankle of external rotation, eversion of the foot, and a little bit of dorsiflexion. But we're seeing basically when you are flattening your feet down like this, you're putting all the weight on the inside of your foot, that you are standing in pronation. When you guys get a chance, take a look at your shoes. Look to see, are you wearing out the inside portion of your shoe more than you're wearing out the outside portion of your shoe, it can sometimes tell you a little bit about whether or not you are pronating too much. So what ends up happening there is because the ankle is sitting at this, misaligned angle there, what ends up happening is if you travel up and look at the tibia and fibula, if you look at their shin here, well, this is going to be internally rotated, right? So now this is falling this way rather than traveling up 90 degrees the way it's supposed to, right? So we are seeing feet externally rotated or flattened feet, and adducted or internally rotated knees. So now we're seeing like the knees are caving in this way. And why is that caving in action happening? Well, there's sort of two things happening in the knee here. There's straight up adduction. Remember, adduction is moving towards your midline, right? And there is also a little bit of internal rotation. The knees are not only just moving, caving in directly, because they're really not designed to do that. Again, if you look at your knee joint, when you look at like, let's see here. This really is not designed to have a lot of like lateral movement. So how the heck can it so effectively like sort of cave in on one side? Well, there has to be like an internal rotation. You'll see this caving in action, this internal sort of rotation here. Give me a picture that I like. There we go. Good Lord, there's a great one. That's not ideal. So here's that kind of classic knees caving, right? You can see this person is very clearly, collapsing their feet inward, right? And then that's causing the knees to cave inward, and we're seeing this rotational inward movement here, right? And look, there's too much of a gap on this side of the knee joint and not enough gap on this side of the knee joint. So this is grinding. That IT band is being overly stretched, right? This is causing like a lot of different problems. That is what we refer to as knee valgus or a knee cave-in posture or pronation distortion syndrome. So what muscles are really causing this? What are our probable overactive muscles that are, really giving us a problem? Well, our tight muscles that we've got are going to be the gastrocnemius. Those are the muscles in your calves, right? Your big calf muscles, and your soleus, which is the miniature calf muscle that's sort of underneath it, right? So we look at the gastrocnemius. It's these muscles right back here that are overactive. I will say, putting a little bit of a distinction here, particularly it tends to be the lateral side of your gastrocnemius that is really the big problem causer. It certainly could be both of them if the knees are caving in, but in particular, this lateral gastrocnemius tends to be kind of the big bad guy here. Then you're also going to see your soleus, which is a little bit of a smaller muscle. You can see here's our gastrocnemius again. Your soleus lives right underneath your gastrocnemius, and it ties from your fibula down to the same spot as your gastrocnemius. So both of them are attached in different spots, but you can see this is attached only to our fibula here. So this is one of the reasons why, like, when you keep your leg nice and straight, it stretches your upper calf muscles, and when you bend your knee, it stretches your lower calf muscles, because by bending the knee, you're taking the pressure off the gastrocnemius by no longer stretching, these two origins right here. And so that's what leads to a deeper stretch in the soleus. That's why we have two sort of different versions of a calf stretch. So if a client has knees caving in problems, both of these muscles are likely overactive. If we are also going to see, it says hip flexors here, but in particular, when they say hip flexors, your hip flexors are a complex. It's a group of muscles. You can see here's your entire hip flexor Actually, that's not the right one. That's not it either. There we go. So your hip flexor complex are these muscles right here called your psoas. These muscles on the inside of your pelvis called your iliacus. That all comes together to make up your iliopsoas, which you can see runs all the way down and grabs the femur here. It's also going to be your sartorius here, and your rectus femoris is a really big one. Those are all like part of the hip flexor complex, but there's another one that's not being shown here, which is right over here in the center. This is your tensor fascia latae, which is this short little muscle that runs from the outside of your hip over to your femur, and then it becomes fascia and runs all the way down to become your IT band. So when we look at that, you can see there's our IT band as it runs all the way down. That is really the portion of the hip flexors that they're talking about here. If your client's knees cave in, it's probably not a problem in their iliopsoas or their rectus femoris for that matter. Really, the big one that we're going to see here is your tensor fascia latae, more commonly called your TFL, or that iliotibial band, your IT band. Those are the two really big bads here, right? Because if you look at like where they're grabbing, right, they're grabbing on the outside. That's actively causing that internal rotation there, right? It's grabbing the outside of the knee. And so when it contracts, it is a hip rotator, right? Then the next one that we're going to see that's likely overactive is going to be your biceps femoris short head. So this is a hamstring muscle. Your biceps femoris short head is a hamstring muscle. It's actually not this one. That's your biceps femoris long head. So here's the long head of the lateral portion of your hamstring. So in your hamstring, you've got a couple different fibers. You can actually see all of them in this picture. You can see we've got a medial side towards the inside part of the thigh. We've got a lateral side towards the outside portion of the thigh, right? Your biceps femoris is the lateral portion. And it has two separate fibers. It has two separate heads here. There we go. That's what I want. And you can actually see both of them here, right? So here's the long one, and here's the short one. So they both insert on the same place. They're both technically like, you know, the same muscle here. But it has like two different heads. Very similar to, you know, the reason this is called your biceps, by the way. I don't know if you guys remember this from looking at the biceps yesterday, but take a look here. You've got a long head and a short head, right? Two separate sets of fibers in your biceps. Your arms and your legs are very similarly designed. So this short head right here, which grabs a little bit further down on this fibula, that is what is really responsible for that rotating action that's happening in the knee. So when we see, again, the knees caving in, this hamstring, this little short hamstring muscle right behind the back of the knee on the outside aspect is the real big bad here. This is really the muscle that's kind of causing a lot of those rotational problems. So now we know it's tight calves, particularly on the outside, tight hamstring, particularly on the outside, tight hip flexors, particularly on the outside. We're starting to see a pattern here, right? And that's all what's causing those knees to cave in. So, and then one more is your entire adductor complex. And now we move to the inside of the thigh. So your adductor complex are all these muscles on the inner thigh that are contracting to pull your knees inward, right? Actually, let's go with this version. So a lot of muscles here, all of them contracting to bring your thigh inward. You know, if you spend all day sitting with your knees, you know, kind of tucked into each other, right? That is certainly going to be activating these muscles right here. They're going to get into a shortened state. They're going to get used to being like that, and they are going to tighten up. So that is your entire adductor complex. They're going to fire and pull that knee inward. So now we know a little bit about our overactive muscles that are causing that pronation distortion syndrome. Overactive muscles are the muscles that we need to turn off. These are muscles that are firing more than they are supposed to. We need to get them to shut down so that we can strengthen the muscles in the opposite direction and draw us back to that neutral posture. So these are the muscles that we're going to stretch. Your probable underactive muscles in pronation distortion syndrome, for the most part, you can often just jump straight to the antagonist. A lot of times you can move from one side of the joint straight to the other. So for instance, if we look at like, if we look at your gastrocnemius, which is on the back of your calf, right? We jump straight to the other side of the bone, straight to the other side of the joint, and there's your anterior tibialis. So that is going to be one of our weakened muscles. This person is a little bit too good at pointing their toe away. They are not so good at pulling their toe back towards them. So the anterior and posterior tibialis muscles, both of which are shin muscles, need to be strengthened. We need to get our client better at pulling their toe towards their face. We're going to see the vastus medialis oblique here. This is more commonly referred to as your VMO. And your VMO is a little quadriceps muscle, but it's on the exact opposite side as that biceps femoris short head, right? So remember, your VMO is this middle, let's see here, let me get a better picture. Actually, you know what? Here's, you can see it in the friggin' VMO always pops in friggin' bodybuilders. This big bulgy muscle on the inside part of the portion, right? That's the VMO. So you've got a lateral quadriceps muscle, you got an intermediate quadriceps muscle, you've got a medial quadriceps muscle, and then you've got one that kind of covers all of them. Well, remember, we saw that biceps femoris short head. Let's see if this works. I'm not sure if this is going to pull anything up. Yeah, so here's your biceps femoris short head. Again, it's the bottom portion outside hamstring muscle. So it's on the posterior part of the thigh. It's on the lateral part of the thigh. It's on the posterolateral part of the thigh, right? So we got to jump to the exact opposite side of the joint. We go to the anterior medial side, and there's your VMO. Anterior because it's on the front, medial because it's on the inside portion. So that's the type of exercise, that's the type of quad exercise we're going to focus on. And then we're going to see we need to strengthen the gluteus maximus, the gluteus medius, and your hip external rotators. So when we look at that TFL, which is a hip internal rotator, right? Right in here, this is a muscle that is overactive. It's a hip internal rotator. What do we need to strengthen? A hip external rotator. So the big one here, your gluteus maximus, your freaking moneymaker, right? This is the main muscle that we need to strengthen to drive those knees out, right? This is also going to work directly opposite of your adductors as well. Not so much the gluteus maximus. The gluteus maximus is working directly opposite the TFL. Your gluteus medius, which is this little side butt muscle, is going to work directly opposite of your adductors, right? So I've got my adductor complex, which would be, caving my knee in like this. And I've got my adductor complex, which is going to pull this way. So my gluteus medius, my side butt muscle right here, that's going to help me with my knees caving in action. And then if I've got, the rotation part that's, I'm not just caving in, I'm also rotating, right? Well, then I also need to strengthen my gluteus maximus, which does external rotation, right? It drives my leg, this way. So what I'm going to do is I'm going to scoop back like that. So exercises where I abduct and externally rotate are going to be the kind of exercises that I focus on to strengthen my glutes. And that's going to fix my knees caving in, right? So we can all put that into a program. We're going to do that here in just a little bit. So that is lower cross syndrome. Any questions on that so far, guys? Thomas, Lorianne, you guys in particular, because you're my two newbies. How are you feeling about that stuff?
Good.
Cool.
Okay, just
moving along.
All righty. So let's take a look at our next piece of posture here, lower cross syndrome, which I kind of talk about a lot anyways. It just is so common. So lower cross syndrome, this is a static posture assessment that is characterized by an anterior pelvic tilt. You can kind of see, if this guy's pelvis was a bucket of water, the water would be spilling out the front, right? So what's causing this? Well, if you look at it, right, we know that it's going to be a tight or overactive gastrocnemius muscle. That one's kind of surprising. It's like, why would the calves be causing this? But what ends up happening is like this tightens up, your client locks their knees, and that allows them to further like drop this down. So we are seeing gastrocnemius and soleus here again. But a little less emphasis on the real big ones here are going to be the hip flexor complex, which is that TFL again, that little hip muscle on the side, right? Now, this is the one where it is going to be the iliopsoas, right? Those muscles that are running all the way from the spine down and grabbing the front of the hip there. And then that rectus femoris, which is running from the hip all the way down to the knee. So the entire hip flexor complex here is basically so tight, it's in charge of doing this action right here. It's in charge of like raising our hip up, right? It drives my knee upwards. But imagine like if you imagine you brought me up like this and then you tied something, from here like into my abs. And then I just dropped my leg down, right? What would it do? It would pull my pelvis forward, right? It would drag it like this. And so we see what I like to affectionately refer to as Instagram booty, right? Somebody's just sticking their butt out like crazy, tilting their pelvis forward here, right? That is your classic anterior pelvic tilt, right? So we see this sort of like anterior, rotation. Actually, I guess this is the more severe of the two. So don't get me wrong. For the record, your pelvis is supposed to sit in slight anterior rotation, just not it shouldn't be like perfectly flat. Actually, good posture is an ever so slight downward turn, but massive downward turn is really intense, right? Like that's a neutral low back. There's a natural lumbar arch there. Here, Instagram booty, right? Big anterior tilt. So the hip flexors are driving the legs down. We're seeing the adductors on here as well, which seems a little surprising because you're like, why would my adductors, which are primarily in charge of like squeezing the thighs inward, be causing the pelvis to move forward? Like that's a frontal plane motion, not a sagittal plane motion. Well, some of your adductors do actually act as hip flexors. So the ones that are tied in the front are causing that kind of forward dumping action. And then here's kind of a surprising one as well. The latissimus dorsi is overactive. So your lats, which are these really big muscles right back here, actually sometimes cause a little bit of this anterior tilting action because they're not so much pulling the pelvis in the front down, they're actually grabbing the pelvis from the back and pulling it up. So you can see this muscle wants to pull this way and it's tied to the back of your pelvis right here in all this little white area. This is called your thoracolumbar fascia. And when that thoracolumbar fascia gets pulled, it gets, it pulls the pelvis upward. So we're starting to see both sides of the problem here, right? I'm pulling my pelvis down in the front and then I'm grabbing the back of my pelvis here and I'm pulling it up in the back, and that's causing that anterior action. So that one is definitely a problem. But the other really big one is your erector spinae. So your erector spinae, which is literally in charge of spinal extension, it wants to make you arch your back, which, by the way, we want this muscle to be strong. This is a great muscle here, right? But if it gets overdeveloped in this portion of the fibers here, it causes too much of that anterior rotation. So we're seeing tightness in the low back, tightness in the hip flexors, maybe a little bit in the lats as well. Those are really, really, really our big ones in terms of overactivity. So yeah, yeah, a little bit in the calves, like gastrocnemius and soleus. Yeah, a little bit in the adductor complex, but really hip flexors, lats, erector spinae. Those are the big bads, right? Meanwhile, all those tight muscles are inhibiting the muscles that are all opposite of them, right? And so if it's your gastrocnemius and soleus, again, the opposites of those, anterior, posterior tibialis. Your calves are tight, your shins are weak. Gluteus maximus and gluteus medius again, right? That is the muscle, right? If your hip flexor is in charge of hip flexion, your glutes are in charge of hip extension. They drive my thigh backwards. So I need to strengthen that by doing things like floor bridges, squats, obviously. Even lunges for those are okay, I guess. All those can be really good. Side to side walking actions, right? Anything that strengthens my glutes and drives that pelvis back into a neutral position. Then we're seeing the transverse abdominis and the internal obliques, which are those core muscles on the exact opposite side of the erector spinae. The erector spinae is on the back of your spine. Well, your transverse abdominis and your internal obliques are on the front of your spine, creating like this nice wall here that is going to stabilize your spine and create intra-abdominal pressure, holding everything in place. So basically, we've got way too much spinal movement happening here rather than just holding and stabilizing our pelvis in a neutral position. And then the reason this is called, and a good way to remember this, guys, the reason they call it lower cross syndrome is because it literally forms a cross here between tight muscles up top and down below, from back to front, and then weak muscles up top to down below, from front to back. So it creates an X, right? Tight to tight, weak to weak, right? And so the pelvis is rotating forward. Erector spinae pulling up, hip flexors pulling down, abdominals trying to pull back up, but they can't because they're weakened, and gluteals trying to pull back down, but they can't because they're weakened, right? They're being inhibited by these opposite muscles. There's no balance in the force, So actually, okay, one nerdy joke for the day. I was having this conversation the other day. We were talking about Star Wars. And we were talking about how that line from the third prequel movie where he's like, Obi-Wan's like yelling at Anakin Skywalker because he's fully gone Darth Vader. And he's like, you were supposed to bring balance to the Force, right? Not destroy it, And my friends and I were talking, and we were like, there were like 1,000 Jedi and 2 Sith. He wiped all the Jedi out. Now, sounds pretty balanced to me. Like now it's nice and even on both sides. Anyway, Jedi shot themselves in the foot. It sounds like they misread that prophecy. There's my nerdy detour for the day. But the Jedi were an overactive muscle and the Sith were underactive. Whether that's a good or a bad thing in this example is up for debate. So let's go ahead and take a look at upper cross syndrome. This is our third and final postural distortion in our static assessments. So upper cross syndrome, the one that probably everybody is dealing with a little bit, thanks to these freaking things, TV and computers and all that. These are muscles. When we see upper cross syndrome, this is a static posture assessment characterized by rounded or protracted shoulders and a forward head posture. So we're seeing this kind of thing, right? So the muscles that are really tight here are going to be your latissimus dorsi. Now, this is kind of one that also this is one that surprises people a little bit again, right? Because you think about your lats are in charge of 3 things, okay? They are in charge of this, where they drive your arms inward like that, right? So adduction of the shoulder. They're also in charge of extension of the shoulder. So they pull back like this. But the other thing that they do is internal shoulder rotation. And that's the one that people often forget about. So because you can see your lat, see how it tucks under the armpit and then ties to the front of the bone? When it pulls like this, it pulls the bone around, internally rotating. That is going to cause the rounded shoulders. You can actually even see it in this picture here. See how his thumbs are like facing inward like this, right? That's an, you know, if he had an externally rotated shoulder, his thumbs would be facing like this. But you can see it here, right? That's the rounded shoulders we're seeing. So the lats are definitely contributing to that. We're also going to see the pectoralis major, but the really big one here is going to be your pectoralis minor. So pec major is this muscle right here that runs to the front of your humerus, and it does cause internal rotation as well. So yes, the pec major is a contributing factor, but the really, really big bad here is the pec minor, which isn't actually grabbing your humerus. I can see this is grabbing your arm, right? Your pec runs from your sternum, grabs the arm. Your pec minor doesn't grab the arm, it grabs your shoulder blade. That's not a good picture. There it is, right? It runs from the ribs, it grabs the front of your shoulder, not your arm. So what that does is that literally pulls your shoulders forward. If you go from here and push like this, that is your pec minor that is doing a good chunk of that movement. It's got a synergist that we're going to talk about here in just a second, but that is definitely an overactive muscle. So when you're stretching your pecs, I like this version of a stretch, but I really like this version a little bit better because that has been shown to get a little bit more pec minor. Just take your arms 6 inches a little bit higher. And then we are seeing, so now we've kind of addressed most of the rounding part, right? It's the pec minor, it's the pec major, it's the lats, right? That's rounding our shoulders forward. But then we got to look at what's causing this dumping action in the head. Why is our head falling so far forward, right? Well, that is going to be your upper trapezius, your trap muscles, right? Which are right here on the side of the neck. You know, up in here, that's what you're kind of massaging every time you're, you know, really kind of digging into a shoulder rub. It is going to be your scalenes, which live underneath that. They are these little tiny neck muscles on the side. They're covered up by your traps for the most part. Then you get your we'll come back to that actually, and your levator scapulae. Which is a little neck muscle in the back of your neck. So that one's back here. And then we are going to see that it is my favorite muscle, the sternocleidomastoid. Yep, this is a big one, right? This friggin' thing is the devil's muscle. It's my favorite muscle because I think its name is goofy, but it's my least favorite muscle to freaking touch. It's so tender. And so it's this little muscle right here on the front. Go get a sternocleidomastoid massage, guys. It'll make you a whole new person, but you got to be tough because it's brutal. So that is this little muscle on the front. So now there we go. This is a great picture. Why didn't I have this version? So there's your upper trapezius, right? There's your sternocleidomastoid. You can actually see your scalenes peeking through underneath here. And then your levator scapula would be just up above this, and it would tie to right about here. So all of those neck muscles are so tight that it is drawing your head forward like this and elevating your shoulders. What's happening is the shoulders are being pulled forward, but they're also elevating slightly. And when that happens, your neck has to try to counterbalance by falling forward like this. So that's what's causing that forward head action. Now, there are two rotator muscles that are also causing this. It's going to be your teres major, which is working with your pec, with your lat to internally rotate. You can see it runs from your scapula, grabs to the front of the arm, and so it pulls it inward like that. And then the same thing is true of your subscapularis, which also lives on the back, of your scapula. I mean, technically it's on the front of your scapula, I guess, but it lives on your scapula and it ties to the front. So both of those muscles internally rotate. So now your lats, teres major, and subscapularis are all working to internally round the shoulders forward. Your pec minor is working to protract your shoulders. And then your trapezius, sternocleidomastoid, levator, and scalenes are all working to elevate your shoulders and drop your head forward. And now we've got this kind of posture here, right? So that is, those are all of our tight muscles, right? We got to move to the opposite side of the joints in a lot of these. So we move to the opposite side. Actually, we'll come back to this one because the serratus is kind of a tricky one. We move to the opposite side of your pec, going from here right to the side. That is going to be your rhomboids. Okay, so your rhomboids are these muscles that live between your shoulder blades, and their job is to contract and retract your shoulders, right? So pec muscles, rhomboid muscles, right? Rhomboids get a lot of help from these other muscles that are back there, which are your middle trapezius. So you've also got middle and lower trapezius muscles, okay? Your middle trapezius is right here in this middle section, and then your lower trapezius is this lower section down here. So the middle trapezius also does shoulder retraction, just like the rhomboids, but then you've also got your lower trapezius, which, you know, if your upper trapezius does this, your lower trapezius does this, right? So one's pulling up, one's pulling down, okay? So we need to strengthen the one that pulls us back down. And then we're seeing your deep cervical flexors plus your infraspinatus. So deep cervical flexors are actually these little stabilizers in your neck. This is one that kind of surprises people. Your deep cervical flexors are actually on the front of your neck. And it might be one of those situations where you're like, wait. We're pulling the head, but why would we strengthen something, you know, here, right? The thing is, they're on the front of your neck, but their job is to do this, not this. Your sternocleidomastoid does this, right? So we actually, what the problem is, like when we've gotten used to when we look down at something, rather than like looking down, you know, at our feet like this, we have clients who are doing this, right? So that's actually an example. This is one of the weird situations where we're not moving to the opposite side of the joint here. Instead, we're actually looking at a synergist muscle. You know, like I said, it's not always the opposite muscle. Sometimes it's a helper muscle that's doing too much work. Robin is basically beating Batman to the punch, you know? So it's not so much the Joker, it's Robin's become the bad guy here. A lot of nerd references today. Shocker, right? So then we have our infraspinatus as well. Your infraspinatus is actually a rotator cuff muscle. And so it works exactly the opposite of your teres major and your subscapularis. So your subscapularis was living on the other side of this bone, grabbing the front of the humerus. Well, this is on the back, grabbing the back. So if one is in charge of, you know, internal rotation, your infraspinatus does external rotation. Same thing with your teres minor. That's also underactive, right? Same spot as the teres major, starts right here on the bottom of the scapula and then grabs the back, right? So the muscles that are grabbing the front have rounded us. We need to strengthen the ones that will pull us back. So we need to do more exercises like this instead of like this. And lastly, one that I skipped a little bit is your serratus anterior. So your serratus is another one that's kind of surprising because this muscle its job is actually shoulder protraction. And that's where you're like, wait, we're doing too much protraction. why would we strengthen a protractor muscle, right? Again, this is an example of the synergist is not able to do its job. So this is the muscle that's supposed to do your protraction. Unfortunately, your pec minor has been doing all the work. So we want to strengthen this muscle so that we can tell it to take over for the pec minor. We need Batman to, tell Robin to shut up. So this is a synergist muscle in this case. And again, that's a protraction movement. So those are our 3 major postural distortions. Now, if you see those things in your clients, obviously you want to start addressing them, right? You want to say, all right, well, we need to strengthen the weak stuff. We need to stretch out the overactive stuff, right? So how are we going to do that? Well, we're going to write a program that's going to address it. So I've got an example program up here. This is not necessarily a full-on program like you would do in the gym. You'll notice there's a little bit too much stretching only here. But if this were like something you did on your off days, these are 3 routines that would basically address what we're talking about to activate the right muscles. So again, let's take a look here. You can see here's pronation distortion syndrome, right? So we've got our feet turn out, feet flatten, knees cave in, right? So the overactive muscles are here. You'll notice I did add the peroneals in there. That wasn't in the PowerPoint. That's another overactive muscle. It lives on the side of your shin, causes eversion. And then we see our underactive muscles on this side. So this is the same list that we saw, but I added one. And now we are going to stretch all of this overactive stuff. So we're going to foam roll the calves, the side of the shin, the adductors, the IT band, your hip flexors, your biceps femoris. We're going to basically foam roll or, SMR, all of that stuff. If I were a massage therapist, these are the muscles I'd be working on, if I saw my client's knees cave in. And then I'm going to follow all of those exercises up with stretches, right? I have foam rolled the calves, therefore I'm going to static stretch the calves. And, that's my gastrocnemius and my soleus. I foam rolled my peroneals, I'm going to do a peroneal stretch. For the record, like I said, your peroneals, they live on the side of your shin. They're right here. So what they do is they evert the foot. They pull like this. So if this is inversion, this is how you stretch the peroneals. They are being pulled like this. So you stretch them in a kind of a weird looking, very simple looking stretch. Usually you'll place your hand on the wall, take your foot back behind you like this, and just drag the top of your foot. Actually, you probably can't see that. Drag the top of your foot into the floor, just like this. And that's actually a peroneal stretch right there. If your feet are flattening, that's a really good one. Then we're going to do a standing adductor stretch, as well as an adductor magnus stretch. So I've got 2 adductor stretches in there because both of those are going to be helpful with the knees caving in. So the classic adductor stretch is right here. You guys are probably familiar with this one, right? But then the adductor magnus is this kind of one where you actually take your foot up and go down and then actually kind of twist away. And that's going to get right in the upper portion. So now you're getting like the lower portion with the standing version. You're getting the upper portion with the foot elevated version. A kneeling hip flexor stretch. So we go into a position like this and we drive our arm up. That's going to stretch out my hip flexors right here. We're going to do a standing TFL stretch, which is really similar, where we go into basically the same position, except that we put our foot down and we really lean over like this. So now I've got the front of my hip flexors in the first one and the side of my hip flexor in the second one. And then, I don't want to do it because I hate the stretch, but I'm gonna, a biceps femoris stretch. So I'm going to elevate my foot onto a surface like this, bring my hands together. Now, a lot of people would just reach for their toes, right? And that's not a bad hamstring stretch as it is. But if I just reach for my toes, see how my hips kicked this way? That's going to get my medial hamstring. That's going to get the inside portion of my hamstring. I need to stretch the lateral portion of my hamstring. So what I'm going to do is I'm actually going to bring my hands together and I'm going to cross over my midline like this. God, I hate it. And that straightens out my hips this way, which stretch the outside portion of my hamstring. So there's a difference in how we do that. For the record, I know I'm moving pretty quick through these guys. We're going to, teach you these in person a lot better. So those are all the stretches. And then I need to strengthen the opposite side, right? I need to look at my weak muscles here, right? How do I strengthen my anterior tib and my posterior tib? How do I strengthen my VMO? How do I strengthen my glutes, my rotators, right? Well, we can see a bridge with hip abduction would be a really good one. That is this exercise right here. So if I put a band around my knees, that causes it to squeeze those knees inward. So then I have to externally rotate. I have to abduct in order to, pull that band apart. And then this person's doing like a floor bridge, right? She's doing like a hip raise, which is literally hip extension. So she goes from the floor and then she drives up. She's doing the feet together thing. You don't have to do that. You can do that, but you don't have to. So that is going to, be a really good way to kind of strengthen the external abductors as well as the regular old hip extensors. I'm going to pair that up with a modified side plank with hip abduction. We actually just saw that a second ago. I don't even need to, where'd it go? Oh, I did see it. There it is. So here's a modified side plank where she's on her knee. That's the modified version. And then she's just going to do a leg raise, right? She's just abducting the thigh away, strengthening the outside part. This is the same muscle that we're working on with the band around the knees, right? But we're just getting a chance to kind of strengthen that abductor. We're going to do a step up to balance, which is a really great exercise where you can see right here. Okay, maybe not. So that's your classic step up to balance there. In this version, we are saying we're going to do it in the frontal and transverse planes. So a regular step up, so a frontal plane, you can actually see here, see how she's standing off to the side? That is allowing her to do more abduction, right? Or she could do a transverse version where she would actually face this way and then twist as she steps up. So she would face this way, but then she would end facing the opposite direction. You can actually see it here, right? Here's a frontal plane down here in the middle, stepping to the side. And then we see the transverse plane where he's facing this way, but then he turns to end facing the other way. And then a box jump to stabilization. We had a question? Nope. So that's this version right here, right? We do a box jump and we land and we hold. That's again going to work on the anterior tib, the gluteus maximus, right? Basically strengthening all that stuff we need to. Any questions on that, guys? Doing good? All right, so we kind of put this little very simple program together, and then we followed up with the same cool down. This would take maybe 20 minutes out of your day to kind of work your way through this entire thing. So if we had a client who did something like this as their homework, 20 minutes a day, maybe 3 days a week, and then they come in and do like strength training with us 3 days a week, this is going to address those postural distortions. So that's an example of how we would kind of write that whole thing together. Now, looking at the lower crossed syndrome, right, that anterior pelvic tilting, it's really similar, except different muscles, right? We're going to start by rolling the calves, but this time we're going to put a little bit more emphasis on the hip flexors We're still going to see the adductors, but now we're going to also add in the lats. So we follow that up with calf stretches, adductor stretches, hip flexor stretches. There's that biceps femoris again. That actually doesn't technically need to be in here. That's funny. I don't know why it's in here, actually. Delete that. Erector spinae, right? So that's the low back, which is very, very tight. So they're going to do a static erector spinae twist. That's basically going to look like this. There's sort of two versions. There's this lying version here, which is really good. Love that stretch, but there's also like this version here where you can just do like a seated version. I don't like this version as much because it's collapsing your spine downward. I like this version because you can lengthen your spine out more. So that's going to help with that anterior tilting. And then a ball lat stretch. We're going to work on, remember your lats are in charge of this. So we're going to stretch it by going like this. So basically you're just going to take it hand on a ball, and that's going to give you a nice deep stretch in that latissimus muscle. You can do it on both if you want, right? What we're just seeing here. So then we need to pull the pelvis back, right? The pelvis is tilted this way. We need to get it back to here, right? So we are going to do a transverse abdominis exercise, right? We need to strengthen the transverse abdominis. That's going to be your classic plank, prone iso abs, NASM's fancy way of saying plank, right? And that's going to get the transverse abdominis. We're going to see that floor bridge again. I know. We're going to see a stability ball bridge, which is totally the same. You use a floor bridge, but any bridge, right? This version right here, where you're doing like a big, hip bridge, that's strengthening the glutes. She's performing hip extension as she comes up. Also, there's the upper body version. Yeah, close, but no cigar. Here we go. This version right here. You can also do that and bridge upwards. I don't know if anybody ever does like hip thrusts. The barbell hip thrust, but this exercise is so good for your glutes. I did this morning. Right there. That is a terrific glute exercise, hip extension. But you can do that on a ball. Then we've got the single leg RDL, really great exercise for the glutes, right? We go down, you can see he's holding that dumbbell in the contralateral hand, and then he's going to drive himself back up. Again, we are in hip flexion right now, and then he stands into hip extension. So we are strengthening those gluteus muscles that perform hip extension. And then split lunges, which are really explosive, really great glute exercise. So we got a little explosive movement in there. We got some stabilizing core movements in there. We got some balance in there, right? All those really good examples. And then lastly, we got upper cross syndrome. We got that rounded shoulders, right? So really here for the foam rolling with rounded shoulders, the only ones we really need to do are the lats and the thoracic spine, right? Then we need to stretch out that lat. We need to stretch out the pectorals. We need to stretch out the upper trapezius, the levator scapula, the sternocleidomastoid, right? We need to get all three of those major neck muscles. And then you'll notice I threw one extra exercise in here, an active pectoral wall stretch with external rotation. What you're going to do is you go into a stretch here, you drive your arm back, and then just a little bit of external rotation with the arm. Love that exercise. That would be like 1 and then be like 8 to 10. So that's what that one would look like. That's a really good one. For strengthening, again, isoprone cobra works really good here, right? The isoprone cobra, we think of it, we look at it, it looks more like a low back exercise. But remember, this is actually like strengthening your lower traps because you are pulling your arms down and back into shoulder retraction. So isoprone cobra is a really good upper back exercise as well as lower back exercise, right? He's not coming very far off the ground, but it's close. Then we've got chin tuck bridges, which is really nothing more than a regular floor bridge, except that you are going to encourage, that's totally not what I'm looking for. Basically, do a classic floor bridge and encourage your client to tuck their chin more. A lot of times what I'll use is I'll take a tennis ball and put it under my client's chin and have them hold that there while they are doing their floor bridges. That's going to be, the bridge is more of a glute exercise, but that little chin tuck activates those deep cervical flexors we were talking about. Then there is also combo number 1. Really great. Okay, that makes sense. Yeah. Whoops. Combo number 1. God, none of that is actually it either. YTAs. So you do 3 versions. You do a Y and then a T and an A, and that's combo number 1. So you go here and you go Y, T, A. And that's going to strengthen your middle and your lower trapezius muscles. Lastly, a reverse medicine ball throw, which is a little bit of a plyometric explosive movement, is basically just throwing that ball up overhead behind you. Kind of a fun one. Not very practical in most gyms, but it's a really great way to kind of strengthen your trapezius muscles because your upper back has to contract to throw that ball backwards. Biomechanically, freaking great exercise. Doing it in the gym, not so practical. So that is how we kind of wrote all this out. Now, again, this is all very much like, this is not a full routine, right? This is a massive amount of stretching, you know, followed by some movement prep stuff, a little bit of core, a little bit of balance exercises, a little bit of explosive plyometrics. And then we don't even have like our major resistance section. But there's no reason you couldn't do any of that before a traditional training session and then follow it up with like, all right, well, now let's go do the bench press. Let's go do some barbell squats. Let's go deadlift, you know, let's do all the traditional stuff. Now that we've activated the right muscles, we turned off the stuff that was firing more than we wanted it to. And we got the stuff that was being lazy. We got that, you know, we woke it up. Let's go do a workout, you know, let's go do the real thing, right? And that's what we'll get into in later classes and stuff. But so any questions today on the posture stuff? How y'all feeling, guys?
I'm feeling great.
Pretty cool. All right. Well, I'm going to go ahead and kill the recording and I will see you guys tomorrow in person. So we are meeting at 9 a.m. Tomorrow at Sochi or at 6 p.m. And this is the big change. Please try to make it tomorrow. This is one of our mandatory, you know, this is going to be regular class time from now on. So that means that, like, you know, if you miss it, it's counted as an absence. We are still masking up. So please make sure you're doing that. At least I believe so. Actually, I'll get confirmation on that today, but I'm 99.99% sure. Especially because it's the gym setting. So so yeah, please bring everything. Yeah, we'll be going over our fitness assessments tomorrow. So we'll be working our way through you know, how to kind of do this fitness assessment stuff. And yeah, that's about all I got for you guys.